This video will describe ways to improve pain psychology assessments using a set of patient-centered questions called the Stanford 5. The Stanford 5 questions were originally developed by Dr. Sean Mackey's team at the Stanford Pain Management Center as a means of helping physicians better understand their patients' perspectives about their pain conditions. These 5 questions inquire about how the patient conceptualizes their pain, how they feel their pain impacts them, their primary treatment goals, and ask about their preferred forms of treatment. Because the answers to the Stanford 5 questions are so clinically useful, and the value of the information so efficiently obtained with so few questions, it is both surprising and disappointing how few pain physicians routinely use them. The value of the Stanford 5 questions is also underappreciated for pain psychologists. The Stanford 5 questions offer a great deal of insight into a patient's psychology concerning their pain, so much so that these questions should arguably be included in the assessment template of every pain psychologist. The following slides give a brief description and rationale for each of the Stanford 5 questions, along with a specific example for how to phrase the question to best benefit a pain psychologist. The first Stanford 5 question assesses the patient's understanding about the causes of their pain. In some cases, patients will display a high degree of knowledge about the biomedical basis of their pain symptoms. However, in many, if not most cases, when the patient verbalizes their beliefs about their pain, it will reveal misperceptions or inaccuracies that can then help the pain physician offer the most useful education to the patient. Inquiring about the patient's pain beliefs is also specifically valuable to the pain psychologist because it frequently gives insight into the sources of the patient's fears and anxieties regarding their pain. A patient may, for example, have beliefs about their pain that cause them to worry at a level greatly exceeding their objective medical diagnosis. Many other patients will be uncertain about the causes of their pain, and uncertainty is also a common source of anxiety because unknown causes of pain and our imaginations are almost always scarier than known causes of pain. Thirdly, asking about a patient's pain beliefs can help the pain psychologist better understand the patient's tendencies to catastrophize their pain symptoms. When catastrophizing tendencies are recognized by the pain psychologist, this can alert them to potentially address this topic through further discussion or treatment. The second question from the Stanford 5 is intended to capture the psychological meaning that the patient attaches to their pain. Whereas the first question more directly assesses the patient's medical knowledge, the second question aims to identify the psychological impact of the patient's diagnosis or prognosis. This second Stanford 5 question, predictably, is more likely to generate responses with stronger emotional content than the first question, and can often be followed by additional open-ended questions to further clarify the patient's meanings or feelings associated with their pain. For example, for many patients, a meaning of their pain is that they are getting old, a response that, when further queried, can identify fears about death, disability, or perhaps trigger memories about aging-related struggles that they may have observed with their own parents or grandparents. Other common themes behind responses to this second question include a loss of value as a person or fears of dependency. The responses to this second Stanford 5 question are often particularly helpful to the pain psychologist for improving their understanding of their patient's anxiety and mood symptoms related to their pain, and why the patient may prefer certain types of pain treatments over others. Question 3 from the Stanford 5 is an open-ended way of learning more about the patient's individual struggles with their pain. Even among patients with the same objective pain diagnosis, their level of disability and the areas in which they are struggling will vary considerably. For a pain treatment program to be maximally effective, whether this program is offered by a pain physician or by a pain psychologist, the treatment program needs to identify and address the major ways that pain is interfering with the quality of life for the patient as an individual. Even though this third Stanford 5 question was designed decades ago, it has arguably never been more valuable for a pain psychologist than the present due to the growing emphasis on patient-centered goals and expanding the definition of pain treatment success beyond the narrow criterion of reductions in pain severity. Question 3 from the Stanford 5 is also useful to the pain psychologist because it helps them to have a conversation about pain with their patient that is less pain-focused and more function and quality of life focused. The fourth question from the Stanford 5 is an extension of the theme of the patient's individual challenges with pain explored in question 3, but now apply to the goal of identifying the patient's individual treatment goals. In the same way that patients with similar pain diagnoses will vary in how pain affects their quality of life, patients with similar pain diagnoses will also vary in their preferences regarding the outcomes of their pain treatments. Although most patients will endorse a desire for reduced pain as part of their treatment, learning about the more individual outcomes that a patient has for their pain treatment requires specific questions, such as the example listed on this slide. For the pain psychologist, the fourth Stanford 5 question has particular value because the majority of treatment goals that patients endorse beyond pain severity reduction reflect goals with strong or even dominant psychology themes, such as improving relationships, emotional stability, sleep habits, self-esteem, and perhaps functional abilities. Therefore, the responses that the pain psychologist obtains from this fourth question often help them to develop a more personalized treatment plan with their patient. The final question from the Stanford 5 assesses the patient's preferred forms of treatment. The patient's responses to this question are valuable for many reasons. First, they make it easier for the pain physician or the pain psychologist to develop a more collaborative treatment plan that integrates the patient's preferences. Secondly, it can help pain providers identify when patients have treatments in mind that are less likely to be helpful in the opinion of the provider, and thereby give the provider an opportunity to reconcile treatment options with the patient. Thirdly, this question can tap into the patient's cultural preferences regarding treatment, and this information can be of great use to the pain psychologist for tailoring their treatment planning and treatment recommendations. Fourth, learning about the patient's treatment preferences can often provide useful insights into why certain treatments may have failed for the patient in the past, or why the patient may have struggled with adhering to certain treatments previously. Finally, the fifth question from the Stanford 5 can have unique value to the pain psychologist because it can foster a discussion about how pain psychology treatments could be included in the treatment program in a way that best fits the patient's preferences.